Hello and welcome everybody to Re-envisioning Crisis Response in America. My name is Alexandra Plant and I'm going to be the moderator at today's fireside chat. And so I am so excited to welcome today Dr. Kenneth Minkoff and Chuck Ingoglia. Dr. Kenneth Minkoff is a certified board psychiatrist, senior system consultant with Zia Partners Incorporated, and an assistant professor at Harvard Medical School. He is recognized as one of the most prominent or preeminent experts on integrated services and systems for individuals with co-occurring serious mental illnesses and substance use disorders. I also am very pleased to welcome Chuck, who is the president and CEO of the National Council for Mental Wellbeing. Chuck leads the national charge to ensure that people living with mental illness and addiction have access to comprehensive, high-quality care that affords every opportunity for recovery. And to accomplish this, he harnesses the voices and support of the more than 3,000 National Council members who serve over 10 million individuals nationwide. So thank you so much, Ken and Chuck, for being here today. Today, we are going to be talking about re-envisioning crisis response. The COVID-19 pandemic has further underscored the dramatic need for mental health and addiction crisis services, as drug overdoses and suicides have really overtaken traffic accidents and many other health conditions as the two leading causes of death among Americans ages 25 to 44. Mental illnesses and substance use disorders are now involved in 1 out of every 8 emergency calls or 911 calls in America. And we do know that the earlier the intervention, the better the long-term prognosis and patient outcomes are. So unfortunately, though, despite this, very few communities in the US have a behavioral health crisis system that would be considered excellent, maybe even good, let alone ideal. So in response to that this year, the National Council, in coordination with the Group for the Advancement of Psychiatry, has recently published a new report to guide progress across the nation in a groundbreaking report known as the Roadmap to the Ideal Crisis System. And Ken, who we have here today and are fortunate to have, was one of the lead authors on that report. So you could say he is much of a family friend to the National Council. We are going to be talking a lot about behavioral health crises today, so I thought I would just do some quick definitions. When we talk about crisis, we are referring to any mental health or substance use emergency, such as an opioid overdose or acute psychological distress that leads to an unstable or dangerous situation affecting the well-being of the individual involved. Crisis systems are then the complex structures and organizations we have in place to respond to these crises. So enough from me, let's jump in. Ken and Chuck, to further ground us in the crisis response, what currently happens when someone has a mental health or a substance use crisis in the US? And let's see, Chuck, would you like to kick us off?
Yeah, sure. Well, Alexandra, first, what a pleasure it is to be here with you and to participate in this session, and especially with Ken as well. So, you think about, there's this misnomer, I think, we frequently refer to the healthcare system. And, the reality is, right, there is no such thing as a healthcare system in the United States. And if there is no such thing as a healthcare system, there really is no such thing, right, as a behavioral health system. And then we kind of further parse that apart in terms of what happens when somebody's in crisis. And the reality is that every community has a different way that they respond to this. Unfortunately, the vast majority of people who are experiencing either a substance use or a mental health challenge that kind of causes them that level of distress The most frequent thing would be that 911 is dispatched and they are the first people who respond to such a crisis. Some parts of the country have co-responder models where police officers might come with a behavioral health practitioner if that call is flagged in that way. And then there are a bunch of places that are experimenting with different types of response, either no police response, coming with EMT, but it is highly variable depending on where you live in the country. Ken, would you agree with that assessment?
Absolutely, Chuck. And I wanted to echo the gratitude that I feel for having been asked to join you in this endeavor. And thank you, Alexandra, for the kind introduction. A couple of things. First of all, Alexandra, you teased everybody in the audience with this wonderful report called The Roadmap to the Ideal Crisis System. I just want to make sure that we let everybody know how they can have access to the report, and either the whole report or the executive summary of the report, because the report is designed for the people who are listening to this presentation. It's designed to be in the hands of real people who are advocating for the right kind of services in their own communities, so that they have a roadmap that they can actually work with to make sure that their community delivers the kinds of crisis services that people and families with mental health and substance challenges of any age, any background, in any place, any insurance, any time can get what they need. And so we have in there community report cards. We have 10 steps for communities to get organized and 10 steps for people to advocate at the state level. And we're going to talk about some of that a little bit later in this, but I just wanted people to get excited about getting their hands on it and know how to get it and use it. And then the second thing is I wanted to say, I just wanted to underscore what Chuck said, is that, when we wrote this report, we started thinking about the way crisis services currently are in this country. And we realized, when we stopped and thought about it on the committee that wrote this report, how much of a gap there is specifically for people with behavioral health, mental health, and or substance conditions, and often those overlapping with people who may have intellectual and developmental disabilities and neurodiversity, between what people get for those types of crises and what people get for any other kind of crisis in this country. And it's very clear that the fact that we have collectively, and I include all the mental health professions in this too, as a nation, allowed us to develop a crisis response system that mostly relies on law enforcement to be the first responder to behavioral health crisis, although there are exceptions and there are some wonderful programs around the country. But to just think it's okay that people who are in behavioral health crisis can have their first contact with a police officer and automatically are at risk for being arrested if they don't do the right thing should be intolerable. And yet it has been until recently the default. And we're still working to get over the idea that somehow behavioral health crises must involve law enforcement, as opposed to having law enforcement be there only if they absolutely are needed, but to have this be a clinical response. And so one of the things everybody should be thinking about as we go into this is the behavioral health crisis system should be considered an essential community service that everybody contributes to and everybody benefits from, just like the fire department, police department, emergency medical services, ambulance services, et cetera. And no one should be like, I have to tell you my insurance before I know what kind of response I'm going to get, whether it's health insurance or fire insurance. Everybody should get a welcoming, inspiring response when they're having a hard time. And nobody should have to wait until they call 911 before there's a way to get help. When you're feeling like you're in crisis, you should get help as soon as possible. And you all know, because you live this, that there are pockets of goodness in your communities, but there are so many places and people who don't get what they need. And that's what we need to change.
As it is, yeah. So we are kind of dealing with a current system that is often ill-equipped and disorganized in response, and I think we all could agree underfunded. Ken, to one of your points, we will share a link to the report and answer any questions that anybody has after the session concludes today. Next question, though, that I wanted to delve into was, what would we want to see in an ideal crisis response system?
Well, Ken, you were already going there, so keep going.
Yeah, thanks. And Chuck, I'm just gonna tell you, I'm gonna hand it back to you when I finish my spiel, so that you can talk about how the National Council is front and center in trying to make this all happen. So first of all, I want to emphasize there are two key elements. I mean, the report that we're encouraging you to all read is 200 pages long, and there's lots and lots and lots of detail in it that we're not going to cover here. But the executive summary, if all you're into is executive summaries, is a lot shorter and more digestible if that's what you want. But there's two critical points. First of all, we have to shoot high for what we want. If we want ideal, excellent crisis systems in every community so that every person gets the right response every time in the right place, then we have to create that as a vision, and we all have to fight to achieve it. We have to stop apologizing for needing services, and we have to stop thinking that we can't get the services that we need and deserve until we can prove to somebody it saves money. We don't do that for heart services and stroke services and cancer services. We should not be doing it for behavioral health crisis services either. The second point is that a crisis system, it has to perform for the whole population. It's not enough simply to have a program somewhere that some people can access. It's better to have that than have no program, but the whole system has to be responsive. In almost every place in the US, if you call 911 and you're having a heart attack, you can be pretty sure an ambulance is going to show up and they're going to take good care of you. That's not true for behavioral health. So when we talk about a system, we talk about three intersecting elements of that system. One is some entity in every community has to be accountable for the performance of that system. And that entity has to have both authority and capacity and be able to bring together funding from all different parts of the system, public, private, local, state, federal, whatever. And it has to include the voice of people with lived experience in a governing and decision-making role. And that may seem radical, but in fact, emergency medical systems in every community are governed in much the same way. It's just that most people are not aware of how they do it. And there need to be performance indicators that system operates along the lines of every person getting the right response every time, making sure that equity and diversity are responded to, so there are no inequities in the system, that involuntary treatment is not inappropriately applied ever, that people are not inappropriately arrested. I mean, let's ask for what we really want. Adults and children are served appropriately throughout the continuum, and on and on and on. Secondly, there needs to be a continuum of crisis services. This is not one program, you plug it in and that's a Band-Aid. Everybody has to have a response from the moment you start feeling you're in crisis, places to call, places to go, like behavioral health urgent care, mobile crisis coming to your house, continuity through the crisis, access to peer support, crisis respite, crisis residential services with medical input, sobering centers, the whole continuum, and then crisis continuing care. So you don't go from a hospital to a routine outpatient visit 3 weeks later, and that's supposed to be good enough. So all of those things are outlined in the report. Section 1, accountability. Section 2, a list of all the different components and capacities. And the third section is when you're in crisis, there actually are a set of best practices that you should be achieving. Things like no force first and welcoming, safe, trauma-informed, inspiring care. guidelines for crisis assessment, suicide prevention, and violence prevention, and things for kids, and things for adolescents, and things for older adults. And we actually know those things, and we put them all in our report, but they're not applied. Unlike emergency medicine, where there are standards that are applied across emergency rooms, we don't do that for behavioral health crisis. So all of those things work together, and communities have to advocate to see that all of that is in place.
Well, Ken, maybe I just comment, one of the reasons those things exist in every community is because 50 years ago, Congress created an emergency management system and began to establish standards that have evolved over time, but really guide that. And I think that is, that's kind of the opportunity that we have now, is to move in that direction. So
and the National Council, I'm going to toss you the line, I promise. And the National Council is front and center because your member organizations are partnering with people with lived experience nationwide, and people are closer to it than anyone, right?
Absolutely. I mean, our members are the ones who are helping to stand this up. And I think, and and we have some emerging structures. I think, Alexandra, you're going to get to this question. We have some other things kind of happening in the environment, which are also going to propel this forward. So the first is this evolving clinical model called the Certified Community Behavioral Health Clinic, which is now available in about 40 states. But they have to serve everyone, no matter their diagnosis or insurance coverage or income. They have to provide 24/7 and services. And I think hooking them into then that local accountability makes a lot of sense. The other thing that's emerging is the federal government has established a new 3-digit phone number for people who are having a substance use or a mental health crisis or are feeling suicidal, that they can call this number. And that number is expected to be operational July next year. And I think there's a lot of activity now happening at the community level to begin planning for that. And Alexandra, your questions about what does good look like become really important, because and why this paper is so important, because we need to give communities some outline to begin to plan against. Now, Ken, I know you're doing some planning work in Ohio. Do you want to just talk about how this is kind of coming together in real time, across mental health and substance use stakeholders?
Oh, sure. So first of all, let me kind of bridge it, because I don't want it to just be Ohio, although Ohio is doing cool things. But, along with the 988, which it was embedded in federal legislation, there's also a lot of federal funding that is going out in a variety of ways through the states, some through expanded block grant funding targeted for crisis services and crisis service planning, some through opportunities for improved Medicaid match for different types of crisis services like mobile crisis and so forth. So every state has funding to help them organize planning, not only for 988, but for an improved continuum of crisis services that would follow upon people making a 988 call. And of course, every state is going to do that in its own way. But if you're an advocate listening to this, you need to, and you're interested in this issue, you need to figure out where your state is planning, how that may be replicated in your local community, and get involved, because there are resources out there for figuring this out. Now, Ohio has done some really cool stuff. My day job is that I have a little consulting company. We do systems consultation. Thanks for the advertisement, Chuck. And we're joining with another small company to do a project for the Ohio Mental Health Department, OMAS, Mental Health and Addiction Services, to do a kind of a baseline assessment of the crisis continuum across Ohio, which involves 80 counties that are organized into 50 what are called ADAMS boards, alcohol, drug, mental health services boards. And then to use that information to say, where are we in our continuum development? And then what kind of regulatory and policy and funding changes do we need to support continued development. But Ohio has adopted a model that they're calling the Ohio Policy Roadmap, which basically has the same vision I just outlined. And it's clear that it's going to take a lot of work to get there, and that, that the voice of all the partners has to be involved, the payers, the boards, the providers, and obviously people with lived experience of mental health and or addiction recovery, family members of children who have their own experiences and so on, so that everybody can really be owning this at the local level. And it's pretty exciting stuff. So
that is really, really cool. Are other states doing this as well that you know of beyond Ohio?
Yeah. So
go ahead, Chuck.
Yeah. So in anticipation of this new phone number 988 being operational, there almost all states right now have some kind of planning process underway, looking at their crisis system. And to really just emphasize what Ken said, if people who are listening to this are interested, they should begin contacting their state officials. It's going to be either their state single state authority who has responsibility for their substance use system, or their mental health authority who are going to be doing this. And those are they're most likely working with consumer and family organizations as well as providers to be doing this planning. So yes, every place around the country is doing that now.
Wow.
Yeah.
So it does sound like there's a lot going on in the crisis response space right now. We've talked about certified community behavioral health centers. We've talked about 988 coming online, and different ways that people can get involved in their local communities with promoting 988 and inclusivity on that front. I guess we all know that progress towards any ideal system doesn't happen overnight. But are there more or additional kind of future developments that are breaking ground and gaining momentum in the crisis response realm? That's either to elaborate on what we've been talking about, or
Let me toss three things into play, okay, that are relevant, I think, for this audience. The first is the growing recognition that private insurance companies, commercial payers, have to pay their fair share. Now, that doesn't mean that because we recognize it, that means everybody's lining up to do it right away. But some of the better crisis systems in the country, like in Arizona, where I live, has all been done with Medicaid and state dollars. And they have developed a very good system, with regional accountable entities that are regional behavioral health authorities, as they call them. But what they just figured out in the last year, I mean, they knew it, but they just kind of light bulb hit them, is that if the crisis service they developed is for everybody. And as everybody knows, 3/4 of everybody in the United States has insurance or Medicare, not Medicaid or uninsured. And anybody can have a behavioral health crisis, not just poor people. And so when people with commercial insurance have been using the Arizona behavioral health crisis system, as good as it is, they get the service for nothing. The insurance companies haven't been paying. And so now, bing, 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 the light bulb goes on and say, why not? Why not? And so everybody should be aware that when you start your planning, invite the payers, all the payers, to the table as partners. Don't just, don't ask them to pay out the minute they show up or they won't come back, but invite them to join in the discussion. And we actually did a project where we were able to do that with major health systems and insurance payers in Grand Rapids, Michigan, and get everybody saying, this is our community. We all have to contribute to the solution. It's not just a public thing. The second big deal is addiction and mental health being on the same page. And this is part of most people's vision for 988 and the crisis system, but it's not a done deal. So for those of you out there who are in addiction recovery, don't just settle back and say it's covered. Speak up. because it needs to be clear at the local level, because this is more local option right now than federal dictate, that 988 applies to everybody. And in the context of the opioid overdose crisis, one of the big advances is the immediate initiation of medication treatment for opioid use disorders in the behavioral health crisis setting, not give Narcan and then make a referral when the person won't make the referral, even if it's the next morning. It's start the treatment immediately, because this is life or death, the same as we would for a stroke or a heart attack. The third major advance is peers. We are increasing in our report, we emphasize that peers are an essential component of crisis service staffing, not just in a special peer program, but every single service throughout the continuum, from mobile crisis to inpatient care. People with lived experience of mental health and addiction and family partners need to be included if you're doing best practice services. So that needs to be part of the fundamental design and cost structure of these services. And increasingly, people are recognizing that for people in crisis, especially, having access to peer support in the context of other professional care can really make a big difference. Chuck, you want to add some things?
No, let's go to the next question.
Yeah, well, it's clear that crisis response is very much embedded into our communities, as you know, it sits at the intersection of mental health and substance use disorders, and it is local communities responding, such as police and fire and rescue. One of the things that we have found, kind of what you touched on though, is that mental health and substance use disorders have historically been treated very separately. And how can crisis systems learn to be responsive to both individuals with substance use and mental health challenges, comorbidity?
Well, I think the point that Ken made a second ago really needs to be underscored. We have an opportunity right now to make sure that happens, and it won't happen unless people speak up and want it to happen, right? So we don't need yet another kind of 911 is for we want everybody who's having a mental health or a substance use crisis to be met by a clinically competent, welcoming, trauma-informed kind of response, and that's got to apply to both. And I think part of the evolution here is that almost all the energy up until now for crisis response has been from the mental health system. Well, that's a mistake, right? We got to make sure that it is inclusive and responsive to both. But Ken, you'll get more into details, won't you?
I will. And, Alexandria set this up at the beginning when she said, I'm a national expert on co-occurring, and then she tossed me the big softball. So, and we actually address this in our report. So first of all, and I think many of you guys know this because either you yourselves or people in the listening audience, or people who have some combination of mental health and substance issues. And as you know, if people are in crisis, they're even more likely to have a combination of mental health and substance issues, whether or not they're diagnosed. I mean, people who are like intoxicated and suicidal are a very high risk population. And in many places, people experience this, well, I can't talk to you about your suicidality until your alcohol level is below the legal limit of driving, which makes no clinical sense whatsoever and makes people feel really pushed away at the moment of their greatest need. So one of the things that we have to think about in crisis services is not only the concept that things like 988 are for everybody, but also that every single service in the crisis continuum is designed with the expectation that individuals who are using that crisis service, as well as potentially their family members, may have various combinations of mental health and substance issues. So in the language that I use, every service in the crisis system and every person providing help needs to be able to be what we call co-occurring capable, and be able to be welcoming and hopeful and provide integrated helpfulness to the people with multiple issues that they're going to routinely see in that particular crisis service. And we want to minimize the degree to which we put rules in place that simply make no sense and make it harder for people to get help in the moment. And, we outlined some very specific examples in the report that local advocates can use to guide the development of their system. But the thing that is important for people to be aware of is that this is a legitimate and achievable vision within existing resources. But if you're a peer advocate and you're walking to the table, you may have some random psychiatrist, and as a psychiatrist, I can feel free to say this, who may say, oh, I can't help people in crisis who are drunk. And you have to be able to pull this report out and say, no, this report says you're wrong. And this was written by psychiatrists. Okay, you have to welcome people in crisis who are intoxicated because they're real people in real distress and they deserve help. And whatever service you're operating, you need to love people who are intoxicated and also having mental health issues at the same time because they're the folks who need you the most.
Well, I don't know about you guys, but listening so far, I'm already feeling more hopeful. It seems like there are a lot of exciting things happening and, really a lot of momentum building. So, and that hasn't always historically been the case in substance use and the mental health realm. So, but to build kind of on that, how do you see behavioral health crisis systems working to actually build hope for folks in the middle of a crisis?
Yeah, so that's a great question. And and Chuck, I think already created the framework for it, but it's really in our report, one of the things we really emphasized is, and I probably should have said this at the beginning, but I didn't, is that the entire continuum, the accountable entity, the components, the continuum of services and capacities, the best practices, everything has to be built on a set of values. So connected to the way our system has been historically designed, where right now the default is that if you're in a behavioral health crisis, the system may be designed to treat you first as a law enforcement issue. We have a long way to go, but let's not be afraid to state what should be and to recognize that systems do have the capacity when they set their mind to it to build systemic responses that are about values like welcoming and hope. Okay. So when people are in crisis, it's often a time when people are at their lowest ebb. Something isn't going well. Something is falling apart. It could be a little bit. It could be a lot. It could be for themselves. It could be for a loved one. And they're desperate for hope. So whatever happens to people in crisis, we need to respond to people with, I'm so glad you're here. The sooner you ask for help, the better. And whether I know exactly how to fix you in the moment or I don't, I just want to let you know that I believe that by coming here, you now have partners who can help you achieve your vision of a meaningful, hopeful, successful life. There's more hope for you because you've come and asked for help than if there wasn't. And I never want anybody to walk away from a crisis experience feeling less hope than before they showed up. And that's built into a best practice framework. Now, that again seems radical, but if you've ever been to a hospital that emphasizes customer service, we can do this in big, complicated health systems with people with all kinds of terrible medical conditions. And we need to be assuming that people with behavioral health needs deserve no less and often need more.
So Ken, I'm also wondering, you talked earlier about the role that people in recovery play, and they should be embedded at every part of the response. I have to imagine that's a huge part of this as well, right? That being able to create that environment of kinship and support. Would you agree with that, Alexandra?
Oh, definitely. Yeah. I mean, especially when you look across research on this topic, the idea of connection, and we've heard about that even more during COVID-19 because there's been a lack of it, but connection is such a powerful thing, and it is on its own a healing force.
Yeah, I totally agree, Chuck. But, you know, I like to push the envelope, especially in terms of my own profession, in the sense of, you know, having peers on your team is essential, but everybody on the team has to share capacities so that you're not pointing people in. Well, I don't talk about that, but they do, you know, like, well, no one can help you understand your medication prescription except the doctor. Like nobody can read a label on a bottle. And the same thing, I don't want, if I'm working on a team with a peer, the peer to me is the interdisciplinary professional expert in hope and recovery. But everybody else on the team has to be able to be, you know, capable of inspiring hope and recovery too. Absolutely. It can't be, I'm going to take your hope away. Hopefully the peer will give it back to you. That's not it at all. Yeah, we all are in this together.
You know, 20 years ago, Ken, I remember visiting a program in Long Beach, California, and an impromptu conversation emerged amongst the leaders of this program about a new social worker they had just hired. And at morning huddle that day, they were expressing skepticism that this particular client could actually achieve recovery, and that maybe they weren't they weren't a good person to be in that program. And what the team decided that day is that social worker needed to leave the program, not the client. And you know, I think having that kind of value embedded in the organization is really important.
Absolutely, absolutely.
One last thing I'm thinking of is just also the powerful role that lived experience can play in providing hope to others to see that other people have gone before them and recovered. One thing that has come up a few times, but that I wanted to touch on is just that in behavioral health responses, we often see police intervening or responding, we see criminal justice involvement. And how can we minimize involuntary interventions and create more welcoming environments for those in crisis?
Yeah, so that's so important because, you know, one of the things that I'm currently involved in a project. So we included a lot of this stuff in the report. And I'm also working on another project with a bunch of judges and other mental health professionals and family members and, you know, so forth, to try to figure out how to modernize quote unquote commitment laws so that people have more opportunities to get connected to care voluntarily rather than being incarcerated, essentially. And so it's very important to have a frame that every single person you encounter in crisis is a valuable human being. And that's really important to remember, especially when they're behaving in such a way as to put themselves or others at risk and are so overwhelmed by their experience that they're unable to ask for the help they need. So the challenge is always at every door, at every access point, to try to put yourself in the person's shoes and to facilitate the ability of people who are in their worst moment and having the hardest time asking for help and being trusting. How do we make ourselves the kind of person that would be easy for anybody to ask for help? And how do we build and hold that trust and hope going forward? At the same time, there are people for whom they are so at risk and so unable to ask for what they need that involuntary intervention is literally life-saving. And we have to have a high degree of regard for the importance of doing that when it's necessary to save people's lives or to prevent them from harming themselves or having terrible consequences. Not leaving it to law enforcement so that if somebody can't accept help, the proper outcome is they get arrested and go to jail. because we're not willing to step in and help them clinically, and to give people every opportunity to regain full control of their lives and decision making as soon as they possibly can. Okay, so it's a delicate balance. And in a crisis system, that's a marker, that's a performance marker. Are there people who should be receiving involuntary interventions who are not and winding up in jail as a consequence? That's bad. Are there people who are being involuntarily detained when they shouldn't be, and there should be more opportunity for them to be engaged voluntarily? That's also bad. And there's no way to get it perfectly right every time, but you need to look at every single instance individually and collectively to keep improving your ability to meet that in the exact right moment, so that more people get the help they need and deserve at the moment they need it, and maintain autonomy and hope as much as possible.
So Ken, I'm a much simpler guy, so I'm just thinking about how so many communities, or more and more communities, are really experimenting with non-police response to crisis. And maybe, that's, do you think, is that too simplistic? I understand the tension here is how do we, but I think my gut tells me having a system that underemphasizes police response, still has it there when necessary, but really, kind of prefers a different response, makes sense to me, kind of theoretically. Would you agree with that?
I would. I mean, when you say it, when you frame it the way you did, it does make me feel sad, because you said, oh, we're experimenting with this new idea. How about we don't send out cops to deal with people with mental health crises? Oh, okay, good idea. How about we don't send out cops to deal with people with heart attacks? Oh, yeah, I thought we figured that one out already. So from my perspective, yeah, this is a big issue for the police community that represents CIT, crisis intervention training teams, is to say, look, we're a valuable component, but stop thinking that police are the solution. Police are the backup. So yes. However, I was also answering at a different level, because of being aware as a psychiatrist that, sometimes people, well, first of all, I have unfortunately seen many experiences where the police officers are nicer than the mental health professionals. And I know that many people have lived experience of really experiencing bad care at the hands of people in my profession. So I'm not, in addition to what you said, I think that people who do the clinical care have to get much better and be held to higher standards of not being abusive of their clinical power, and neither over committing or under committing, because I've seen many people who just let people, oh, well, he's behaving badly, let's call the cops, instead of like, wait a minute, or he's not behaving well here, but he's so psychotic and paranoid that we can't keep him in the drop-in center. Well, let's kick him out. Oh, good. Now he'll get arrested. Good plan. Because, somehow we don't have any other means for helping somebody get safe. So I think everybody needs to step up. That's kind of what I'm.
Point taken.
In this same vein of trying to create welcoming environments that encourage folks to seek out recovery, one of the concepts that I know I hear a lot these days is person-centered care. And then we kind of makes me think of, well, what could be a person-centered crisis response system? And that kind of leads into thinking about, how can crisis response systems also tailor to adolescents or folks of different ages or people of different cultural backgrounds? Chuck, you wanna?
No, I would just say that's a very hot topic. I know I was just talking to
it's hot off the griddle.
I was just talking to the head of the National Association of State Mental Health Program Directors, and they just had a session about this at their annual meeting, because we have to be able to think about different response for different kinds of ages, and I would imagine this is a fairly underdeveloped topic in most communities, right, Ken?
Absolutely. And I think it's so, I'm glad Alexandra brought it up because, first of all, there are many communities that have services for adults and no services for kids.
Absolutely.
There are many communities where services are not really designed, and probably the highest risk groups are the people who are undocumented, who are terrified to get help, and people feel like in many instances they're not allowed to serve them or something because of funding restrictions. So the first important message is that when you're developing a crisis system, you actually have to pay attention to your whole population. You really have to think about who's out there and who's in crisis, and you cannot be satisfied if the people who access your service all look or sound a certain way or all have a certain age. You have to be thinking always in crisis that the people, you want to design it to make it easy for the people who are having the hardest time coming in. And that means, as Chuck said, different strokes for different folks, but simply identifying and measuring how you respond to people differently is really, really, really important. And then looking at, does the cultural linguistic mix of your crisis response match the community that you're trying to serve? Do you have services that feel welcoming to people from different cultural backgrounds? Do you have clear instructions for how to respond to people who may be transgender or are questioning their gender identity, who are in behavioral health crisis, and the first thing you ask, are you male or female? And there's no other answer. You have to think about this at every level of detail through the lens of the person who may be coming in at the worst possible time. In a way, that's the aspect of welcoming. There's lots to person-centered, but the way I start the thinking is that it begins with customer service. Okay. And if anyone has ever had customer service training, like in a department store or a restaurant, they teach you very specifically, not just how to talk to the easy customers, but they talk about the challenging customers. And we haven't done that in behavioral health. We are so busy just saying we have our system and you have to fit in it, that we don't take the time to make sure everybody has instructions for, here's somebody in crisis who doesn't easily fit into whatever we design. So what do we say and do to make it easy for them in this moment? Here's a script. Here's a handout. Here's the procedure you follow to get the best chance of engaging this kind of person who's having a hard time.
Well, yeah. Well, Chuck and Ken, thank you for being willing to talk a little bit more about a topic that for sure is hot off the press right now. What is the phrase? The phrase is when in Rome. And I was thinking that we are here today at Mobilize Recovery. And so I would be absolutely remiss if we didn't talk a little advocacy. What can people do, or, folks who are on the call today, what can they do or we do in our local communities to support an improved crisis response?
So I mentioned earlier, so that there is this planning process underway in every state. If that appeals to you, you could try to get involved in that. States now also have to figure out how they're going to fund this crisis system. And one of the advantages of having a new 3-digit number is that the same way that 911 is funded around the country by fees on cell phones, so states right now are passing bills that would allow fees to be collected to fund the 988 infrastructure. If you like dealing with your state legislature, there's some opportunity there. We're also working at the federal level to get additional funding identified to make this system work. So you can be in touch with the National Council or other organizations that are engaging in that kind of work. Ken, any other ideas from you?
Yeah, I think that's a really great question. One of the things that we included in our report that I mentioned earlier is something called 10 Steps for Communities to Get Organized. And so I'll mention quickly what some of the 10 steps are, just so you guys have an idea. This is not rocket science, but on the other hand, it isn't easy. But the first message is you should ask yourself, I'm going to assume that everyone listening is in a community somewhere. And so ask yourself, so if we were going to design an ideal crisis system in my community, in my city, in my county, and my whatever, however it's organized in your state, who's responsible for it? And you look around and you think, oh, well, maybe they're responsible for, but no, they only deal with Medicaid. Or, well, over there, oh no, but that's just the sheriff. They're only dealing with the, people who commit crimes or whatever. And you realize immediately that it's a very big problem that affects lots of everybody. And there's no entity that's fully holding the responsibility for the whole population. So this becomes a natural reason why there's a need for the community to get together and start creating an organized collaboration that says we want an ideal crisis system for all of us, and we're going to come to the table. Now, first thing that I've learned doing this with lots and lots of communities is in many communities, the most important individual or individuals who hold the thing together with passion are people with lived experience, either for themselves or as family members, because they're the ones who hold the heart and soul of the whole project. They're not like in a job that they can come and go. They're in a life. And especially if you're not the person yourself who does this kind of thing, then you may know people who have both, positioning in the community and a willingness to talk about their lived experience. But those people often can bring lots of people together and help everybody to get organized and build a structure, attract local funding to invest in it, and really take the time that's necessary to build a good, strong, powerful collaboration. Don't worry that you won't get everybody to the table at once. As they say in AA, it's a program of attraction. Build something beautiful and attractive and keep welcoming people to join until everybody realizes that you're holding the right collaboration and everybody has an opportunity to win. When you start, one of the things we recommend is you pick up the roadmap report and have everybody read at least part of it. Get excited about a shared vision, write it down and disseminate it. And then we have like a self-assessment community report card that communities can use to say, well, where are we? And let's pick some next steps to work on and so forth and so on. So there really are 10 steps to follow, but don't underestimate the power of lived experience advocacy to bring people together in an organized way and create a formal structure for collaboration across payers and different levels of government and different types of responsibility to build something that everybody in the community can be proud of.
That's super interesting. And again, we will be sharing the report so that folks can, see exactly what Ken is talking about and look at the 10 steps for yourself in your own community. Being at a Recovery Month event in Recovery Month, I think there are just so many, as you guys highlighted, so many ways, big and small, to get involved and do things in your local community. I know in terms of crisis response, Narcan or availability of naloxone is a huge issue and one that's gaining ground. Additionally, there are training programs. So I went through mental health first aid earlier this year, but it's, training that mental health crises can be responded to similar to how you would respond to a first, a physical injury, a bee sting, a first aid situation. So the more education, the more advocacy, the better. So we are getting close to time. So we are going to be wrapping things up, but I just wanted to ask Chuck and Ken, should we be hopeful? How hopeful should we be about crisis response? Any last words?
Well, I think this is a turning point, I think, for our country and our system. But something that Ken said earlier, we're not gonna be done tomorrow, right? But we're at a really good point. There's a lot of energy, a lot of focus, some new resources, and we have to be accountable. I think we have to make sure that it actually comes to ends up in a good place. Ken, are you feeling hopeful?
Absolutely. I do. I totally agree with you that we're in a transformative time, but we also have to remember that what we now know is our 911 system took decades to get from initial concept to full realization. So to me, this is a process of recovery for systems. And we need to get organized using the roadmap to make progress a day at a time with rounds of applause for every day of success, but not stop in the middle, but keep going. So just, apropos of what Alexandra said, like around the lock zone and things like that, what we know is we can respond in the moment to a crisis, but then the person has to be connected. And we need to be moving away from, well, we stabilize you and then we refer you, to we have to make the system bring the continuity to where you are, especially when you're at your worst. So that's starting medication treatment right there after you're revived. Like, here you are, you don't have to come back tomorrow. We'll start you right now. We're not letting you go because we're worried you might die. And we're not going to refer you to some appointment next week because that you may not even get to. Here's a bunch of people who can help you. They can come to your house if you want to. They can be available tomorrow. We're going to stay engaged with you because you're a really important person. So all these elements, if we just design everything over time with people in the middle, and we all continue to speak of the importance of people with mental health and or substance use disorders as being really important customers of our total community, I think we'll eventually get closer to where we need to go.
Well, thank you, Ken, and thank you, Chuck, so much today for being our fearless leaders, leading us through the waters of crisis system response.
Well, thank you, Alexandra, for leading us through the waters of this conversation.
I think there's so much to look forward to in crisis response, and really a focus right now on compassion and empathy and valuing each human life, and wanting to see everybody succeed, and knowing that everybody can succeed in improving their well-being and recovery. And so thank you all again, and thank you everybody on the call as well who has tuned in today, and we will be online to answer any questions. But thank you as well to the whole Mobilized Recovery team for having us, and have a great afternoon.